Welcome everyone, my name is Ramesh. I'm one of the residents at Nepean Hospital. This lecture will be on haematuria from the urological perspective. Haematuria refers to the presence of blood in urine. It can be further divided into macroscopic haematuria or gross haematuria, which is visible to the naked eye, and microscopic haematuria. This is formally defined as the presence of 3 or more red blood cells on microscopic evaluation per high-powered view. This can be further divided into painful and painless macroscopic haematuria, asymptomatic and symptomatic microscopic haematuria, and there is also a category referred to as spurious haematuria. These can be false positives, for example contamination from menstruation, and can be due to pigments such as those found in certain medications and foods. When it comes to diagnosing microscopic haematuria, you might wonder whether your bedside urine dipstick is good enough. The take-home message is that the gold standard is the microscopy you get from your formal urine MCS. The dipstick, while it has reasonable sensitivity, it has low specificity, so you get quite a few false positives. That's because the oxidation reaction which it relies on can be caused by various other substances in the urine. The other thing to note, which you can see on the bottom right hand of your screen, is that if you recall our definition of microscopic haematuria being 3 blood cells per high-powered field, at this range the dipstick's performance is quite variable. So really, urine MCS and the microscopy that comes out of it should be used to diagnose microscopic haematuria. The significance of haematuria is that about 1 in 4 patients with macroscopic haematuria will have a urological cancer. If you consider microscopic haematuria without symptoms, then about 10% at least of these patients will also have a cancer. That's quite significant because if you consider a waiting room of 10 patients who have smoking as a history and all have microscopic haematuria present in their urine with no symptoms, at least 1 in 10 of these patients are going to have a urological cancer. Therefore, it's very important that these patients are evaluated appropriately when this is present. So among the patients who have haematuria who go on to be subsequently diagnosed with a urological cancer, the vast majority have bladder cancer, 80%. 10% will have a renal cancer, and 7% will have an upper tract urothelial carcinoma. Only 3% of patients will have a prostate cancer. As you would have realized by now, the management goal in these patients is to rule out significant underlying urological pathology. But before we go there, it's important that we don't fall into some of the common traps. Firstly, a patient being on anticoagulation does not make their haematuria normal or benign. A normal urothelial tract should not bleed, even if you are on an anticoagulant or an antiplatelet agent. Secondly, haematuria that is intermittent, that is, that comes and goes, is not less sinister. In fact, haematuria secondary to a malignancy is often intermittent. Even if your patient has a single episode of visible haematuria, this should not be ignored or taken less seriously, and they should have the same management as someone with ongoing visible haematuria. Although the focus in haematuria is diagnosing malignancy, it is important to be aware of other causes. You can have infective causes that can range from bacterial, mycobacterial, or parasitic that cause it. There can be inflammatory conditions such as interstitial cystitis. Stones can do it, and especially important to remember that stents that are commonly placed after a stone for some period of time can cause haematuria as well. Trauma that causes renal and bladder injuries. We can cause it ourselves, for example, through traumatic catheter insertion. And there are various other causes, including benign prostatic hyperplasia, patients who've had radiation causing radiation cystitis, chemotherapeutic agents, and arteriovenous malformations in the urological tract. Although a complete history is required, I thought I'd point out certain specifics that are important in a haematuria history. Firstly, you'd want to know when the haematuria is noticed. Haematuria at the beginning of the stream that subsides indicates a distal etiology. In contrast, if hematuria is mixed and throughout the stream, this indicates more of an upper tract etiology. When you see urologists or your registrars ask about the presence of clots, this is an indicator of the significance or the severity of the bleeding. You'd want to ask about risk factors, and there are two main risk factors you need to be aware of: smoking, which is a number one risk factor for bladder cancer, and occupational risk factors. This focuses on occupations where patients are exposed to aromatic amines and benzene compounds, as listed below. You also want to find out about previous cancers and any chemotherapeutic or radiation therapies they've been on. History of stones is important as it may clue you into the presence of urolithiasis or the presence of stents that might be still inside you causing the hematuria. You want to ask about pain. A constant pain may be indicative of an infective cause or a concurrent infection going on. And obviously a renal colic will also point you towards a direction of a stone. Infective symptoms are important as several UTIs can cause macroscopic hematuria. LUT symptoms, which is lower urinary tract symptoms, may point to BPH. A family history of renal and urological disease is important for risk stratification. And it's important to get a history of analgesic use, as certain now historical analgesics are known to cause hematuria. A thorough examination is an important part of your workup for hematuria. The abdominal examination is actually low yield, although it sounds quite blasphemous to say that. The reason for this is because a normal exam doesn't exclude any serious pathology. What you may find is a flank mass, which you can see in a large renal cancer or polycystic kidney disease. Flank tenderness can clue you into infection or obstruction, and you may see a palpable bladder if it's enlarged. A digital rectal exam is a must to try and clarify the nature of any underlying prostate pathology. You want to look for signs of renal disease like hypertension, edema. Signs of systemic illness such as anemia and cachexia are also important to note. The investigations you'll utilize are urine analysis and a urine MCS, baseline bloods including coagulation profile, cytology, imaging, which is renal tract ultrasound, or a CT-IVP, which stands for intravenous pyelogram. Note that essentially a CT-IVP is the same thing as CT urography or a CT urogram. And finally, a cystoscopy. And we'll discuss these in more detail in the following slides. Urine cytology is a specific test, but it's not very sensitive, meaning that a negative cytology doesn't really help you prove anything, but when it's positive, it's highly indicative of the presence of an underlying malignancy. Things to remember are that 1, it's not helpful when there is concurrent inflammation. So if there is autoimmune inflammation or inflammation caused by infection, it is not a reliable result. The second thing is it's not very widely accepted internationally. Some countries recommend it in the workup, others don't. In my experience, we generally do like to have a urine cytology result in Australia when evaluating hematuria. It needs to be done in 3 separate samples, ideally on 3 separate days, and it's important that you tell your patient to do it on any void except the first void of the day. Ultrasound is not the most sensitive form of imaging investigation, but it does have some good advantages. It provides you good information about renal anatomy. It's very, very good at differentiating between solid and cystic masses. It can give you information about obstruction, and it's got no radiation, which is really important for your younger patients. It's also quite easily to get and quite cheap. The disadvantages are it's not good in your obese patients. It is operator dependent. It doesn't give you much information about the ureters, and overall, it's not as sensitive as CT scan. The CT intravenous pyelogram is essentially the same investigation as a CT urogram. It's a multiphasic scan, which is quite important to remember. So the way this is done is, first the CT is done without any contrast being given. This is important as it gives you a good picture of the anatomy and it's particularly important to visualize stones. Once you insert contrast and it enters a renal tract, any presence of underlying renal stones will not be visible. The arterial phase, which is all these phases are based on timing post contrast being given, and they have different utilities. So the arterial phase gives you a good picture of the vascular supply and early cortical flow. The nephrogram phase gives you good images of the contrast and medulla, and whether a mass is contrast enhancing or not is actually quite important for the diagnosis. And then finally, the delayed or excretory phase is when the contrast fills through the collecting systems, and filling defects here are indicative of cancer. The advantage of CT-IVP is that it gives you very good definition of underlying renal masses, and it's very good for evaluating your upper tract tumors, and it's a most sensitive and specific imaging modality. The disadvantage is that it's high radiation, which is bad for your younger patients. It requires contrast, which is not good for patients with contrast allergies, or more importantly, patients with poor renal function, as contrast can induce nephropathy itself. And finally is that it's quite expensive. A very important disadvantage to be aware of is that it does not have good sensitivity with detecting bladder masses in general. This is why cystoscopy, as we'll discuss, is an important part of the workup. Cystoscopy is the only investigation that allows you to reliably rule out a bladder cancer. CT scans cannot detect bladder cancers with any degree of sensitivity that allows you to use it as a diagnostic modality. So if you're considering a lower tract tumor, you must do a cystoscopy. A cystoscope is an optical instrument that enables visualization of the urothelial lining, and it enables you to take biopsies to be sent for histopathological diagnosis. Another thing you can do is a retrograde pyelogram when you're there, if the upper tracts are not yet visualized, but this is not as sensitive as doing a formal CT intravenous pyelogram. I'd like to remind you here that when you have hematuria, you have to investigate both the upper tract and the lower tract, and there are different modalities to doing these. Your imaging modalities are pretty good for your upper tract malignancy diagnoses. However, with your lower tract, your bladder and below, you need to use cystoscopy. Imaging is not reliable. So let's try and put this all together. When you have hematuria, the first thing you do is confirm its presence with microscopy. If you have an alternative source, then you treat that first. So if you're concerned about a renal stone based on history, then get a CT KUB, which is a non-contrast scan, and treat the stone if it's present. If a patient has a UTI, treat the UTI, and then repeat the urine MCS in 4 to 6 weeks. Patients who have gross hematuria or symptomatic microscopic hematuria will require a full workup. Primarily, this involves cytology, cystoscopy, and some form of upper tract imaging. CT intravenous pyelogram is a gold standard imaging modality and will be used in almost all cases. If you have a younger patient, then a urologist will consider risk factors versus a radiation risk of this CT scan and may start off with an ultrasound. For patients with asymptomatic non-visible hematuria, as outlined in the top of the slide, you would rule out benign causes and treat if present. Then it becomes an age thing, deciding what to do next. Patients above 35 should have full investigations as per gross hematuria. If they're less than 35 years old, then the decision to perform all the investigations, especially the CT scan, is based on risk factors and usually a discussion that happens with the urologist. This flowchart is taken out of WA Diagnostic Imaging Pathways, which is more intended to help practitioners decide what sort of imaging modalities to use. It's slightly different to the workup above, especially with the age cutoff at 40, but the main themes remain present in that patients above 35 or 40 with risk factors get a full workup, whereas younger patients and those without risk factors, you consider ultrasound first instead of the CT scan, to prevent unnecessary radiation exposure. This is not a decision that you will need to make as a junior doctor. Finally, it's important to remember that when you do have hematuria, don't forget about glomerular disease as a cause and consider referral to a renal physician for further evaluation. Things that clue you into this would be proteinuria, the presence of cellular CAS, new hypertension or worsening hypertension that's refractory to treatment, intercurrent respiratory infection, reduced renal function, and any finding concerning for the presence of nephrotic or nephritic syndrome. But also keep in mind that if any of these are present, this should not preclude a urological workup for malignancy. So what if you do all the workup and you find nothing? This situation is not all that uncommon. You reassure the patient because the probability of missing malignant disease after a complete and appropriate workup is less than 2%. And you're not going to stop and do nothing. You do keep an eye on them for the next few years. So you do a urine analysis annually for the first 2 years, and if persistent after negative evaluation, you repeat your entire workup in 3 to 5 years, especially in those with risk factors. Given that the presence of hematuria is concerning for malignancy, you may be wondering whether there is a role of screening. Currently, screening for hematuria with UA in patients who are asymptomatic is not recommended and not part of any guidelines. A tutorial on hematuria would not be completed without outlining very briefly what we do in the acute setting. A patient who comes in with macroscopic hematuria or hematuria with clots and they go into urinary retention, then they need urological intervention. What we do is insert a large 3-way catheter, and firstly, through the main channel, you wash out these clots. So you take a 50 ml syringe and you inject and you draw out to try and break up or withdraw these clots. Then this 3-way system allows you to irrigate the bladder, which prevents clot formation and helps the hematuria resolve. This is something that's best learned in person, best to see it done in the urology ward or in ED. I've just outlined or included a link that shows it being done in the ED setting.